Okay. Hello, everyone. Good morning, good afternoon, good evening. We're going to get started. We had over 150 people registered. As they start coming on, we're going to get started so we can get through the webinar and have lots of time for questions and answers. So we're very pleased to welcome you to the data collection webinar series organized by the Data and Analytics section here at UNICEF headquarters. Today is the third webinar in this 2022 spring series. My name is Archana Dwabedi, and I work in the data collection unit here at UNICEF. Just as a reminder, on May 18th, which was 3 weeks ago, we tend to do this every 2 weeks, but there are a couple of anomalies in the next few sessions. But 3 weeks ago, we covered surveying children and their caregivers about access to ICTs, opportunities, and risks in the digital environment. And forthcoming webinars include child food insecurity and bullying, just to name a few. We will be covering topics that have recently gained relevance or importance and where there's ongoing work on how best to collect data. Before I hand it over to our chair, just some housekeeping rules. We have scheduled an hour and 15 minutes today, which includes Q&A. And as always, throughout the webinar, please remain muted and kindly write your questions in the chat box. We will try and group these and direct them to the presenters during the Q&A, and we'll help the chair do that. This webinar is being recorded and will be available in our SharePoint site for UNICEF colleagues, together with past webinars. We will also post these on the MIX YouTube channel, which are publicly available. You can find these links, both of these links, in the email that we had sent to you earlier. I'm going to give the floor to Ava, but just a little bit of a background about her. She is the statistics specialist in the data and analytics section at DAPM at UNICEF. She is a household survey expert with UNICEF's MIX program. Her expertise in survey methodology includes questionnaire design and testing, data collection techniques, human research compliance, and data analysis to support child rights monitoring and evidence-based programming. Just to mention that before she joined UNICEF in 2015, she worked with the Earth Institute at Columbia University, and prior to that, she was with Oxfam for 8 years. So Ava, I'm going to turn it over to you.
Thank you, Archana, and hello, everyone. Today's webinar is entitled Data Collection on Adolescent Mental Health. And we're very happy to have with us Brandon Kohrt, who's a professor of psychiatry, global health and anthropology, and the director of the Division of Global Mental Health at George Washington University. We also have Liliana Carvajal. She's a statistics and monitoring specialist with the data and analytics section at the DAPM UNICEF HQ. Also, just wanted to give a brief introduction of both of them. Brandon is a psychiatrist and anthropologist who has worked for 25 years to improve mental health services in countries affected by war and political violence, disasters, and other forms of adversity. He is the academic partner lead for the WHO UNICEF EQUIP initiative, an initiative to establish competency frameworks and assessments for providers of psychological and other mental health services. And since 2018, Brandon has served as technical advisor to the UNICEF's initiative to measure mental health of adolescents at the population level. So welcome, Brandon. And Liliana is the focal point for maternal, newborn, child, and adolescent health in the Division of Data Analysis, Planning, and Monitoring at UNICEF HQ. She's an epidemiologist with over 15 years of experience in global health and has published several articles in public health journals analyzing data on key indicators and determinants of health. Liliana is leading a global effort to measure mental health among adolescents at the population level, which is spearheaded by UNICEF in collaboration with WHO, academia, and other partners. And Before joining UNICEF 10 years ago, Liliana worked with other UN organizations. So today, we're talking about adolescent mental health. And, I wanted to just briefly maybe introduce the topic. Mental disorders are a leading burden of disease for adolescents. And yet, data on adolescent mental health conditions remain sparse, especially in low and middle income countries. These data are urgently needed to guide strategic actions to address the burden of mental health problems among adolescents through effective policies and programs. This webinar today will address technical aspects related to collecting data on mental health at the population level, including how to adapt tools in specific settings, also recent experiences in testing and piloting of tools in a few countries, and ongoing efforts in addressing challenges in measuring mental health. So Brandon will start the presentation, providing us with an overview of data collection in this area, and Liliana will follow, presenting recent experiences in testing and piloting data collection tools. Brandon, the floor is yours.
Thanks so much. I'm just delighted to share this opportunity with Liliana today and talk about the work with adolescent mental health and the MAP project. So I really appreciate the invitation. I'm going to provide kind of a general overview of kind of 4 key areas where there's often challenges when we think about the measurement of adolescent mental health. I'm really pleased, having done this for more than 2.5 decades now, to be at a point where it's no longer the question of, do we have to measure adolescent mental health needs, but really how best do we do that? And the political commitment, the funding, the acknowledgement that this really matters has just grown. And I think COVID further escalated that with experiences around the world, with the impact on children and adolescents being not able to go to in-person school, forms of grief and loss, and other forms of stressors. So today we really focus on not why do we need to do it, because we all know that's important, but really to focus on how best do we do that. Okay, so the 4 areas that I'll cover briefly. First is really the importance of adapting tools. How do we manage to do that adaptation process? Thinking about the issue that we have to work in many different languages, often even within a single country, to develop national representative prevalence rates of adolescent mental health needs. We have to be able to combine data across multiple languages. The other is that there's often this fear or concern that how can we go and start assessing mental health needs if there's not a robust mental health infrastructure in the country? Is this ethical? Is this safe? And we'll address some of those concerns, including in particular when working in humanitarian context. The third then is when working with enumerators, while there's often excellent training in terms of other forms of data collection, there are some areas that are more unique to mental health assessments. And so I'll highlight some of those key issues that I've experienced and also we've learned from the MAP project. And then in terms of the last part, really is making sure that we have accurate results. How do we interpret the information we get? We can't simply take the numbers from these scores that are obtained in each country and then have something that we can directly translate into prevalence rates. We have to actually make adjustments based on the psychometric properties. But I'll show how, although that's needed, it's actually not that difficult to do. And with the increasing validation work of the MAP project, we're getting standards for many parts of the world to be able to make those accurate adjustments in analyses. Okay, so for the first part, in terms of adaptation of tools, the key here really is that these tools are culturally equivalent. That when we're talking about adolescents with depression in Zimbabwe versus in Belize versus in Nepal, we're talking about similar things. And although there's great cultural diversity and kind of the understanding and interpretation, many of the core features of things like depression, anxiety, and other forms of mental health conditions have very much universal aspects. That said, we need to make sure that we're adjusting the tools to be able to capture that accurately in each setting. Some of the key things that need to be determined for every mental health assessment tool are, one, that it's understandable by that particular population. That includes availability in different languages, that it's relevant for that context, that we're asking about symptoms that mean something in a particular setting, depending on access to digital technology, depending on schooling, depending on other types of life experiences. Certain types of traditional ways we ask about symptoms may or may not be relevant. A very, very important piece is to make sure that when we adapt these tools, that we don't use technical language that becomes stigmatizing in some way. We risk really underestimating the prevalence of mental health conditions if there's a lot of technical or stigmatizing language. And lastly, that when we're adapting these tools, that we're adapting it in a way that we're not just asking about experiences that are common to many different children or kind of normative behaviors within that context, but really that the adapted versions are associated with distress and impairment, which is what we see as the hallmarks of mental health conditions. And from a measurement perspective, the two key things that I want to focus on today are that the adaptation process and then the analytic process are really targeting on reducing false positives and false negatives in these tools. When we use a screening tool in mental health, we're trying to approximate whether or not someone would be diagnosed by a mental health condition by a mental health professional in that setting. We know that all of these tools that we'll discuss today and all in the field often have a certain amount of false positives, and that's true very much in high-income countries in English language versions of the tool, as well as around the world in diverse settings. That means that often a certain number of people who score above a cutoff for something like depression or anxiety on a screening tool, when evaluated by a mental health clinician, would not actually have the condition. That's referred to as false positive. False positives are problematic for a number of reasons, and we'll talk about how we can try to reduce that. And then the other thing is to make sure that these tools are capturing those adolescents who need services, that we don't run the risk of false negatives, of being in a situation where someone scores below a cutoff in an adapted and translated tool who could actually benefit from services, and that when getting kind of nationally representative prevalence data, that you don't underestimate the burden overall. So just as a quick aside, I've found, sadly, over the past year, 2 years, that when talking about false positives, false negatives in terms of mental health, it's so much easier because we always have these COVID examples now. So here's an example of my 5-year-old daughter's COVID test from back in December when she was finally positive, had to keep her home from school. But we've learned that false positives and false negatives are part of any type of health assessment, not just mental health, but also very much physical health. We want to reduce false positives because I want to be able to send my kids to school and they're healthy, so I want to make sure a test doesn't have false positives. But for COVID, also false negatives are very problematic. I want to make sure that all the kids in my daughter's classroom don't have false negatives, come to school and actually have COVID. Now, as we know, no tests are perfect. And if that's going to be true for a biological marker, of course, that's going to be true for mental health as well. I just want to give one quick aside about why this is so important and why adaptation and validation really, really matters. But I'm going to use actually a biological example to illustrate that. Very early days in the COVID outbreak, we saw that there was this study that came out of Harvard on Santa Clara County and estimated a huge prevalence of COVID there. This is even in March, April of 2020. And then when they compared this with deaths, they actually found very few deaths amongst this population. And this led to some early uptake of the idea that actually COVID was not very fatal, that maximum, you might have 10,000 people die in the US throughout the entire epidemic. We know that is not true. And it came down to an issue of false positives, that the way that COVID was tested, and the particular test for seropositivity, had a very, very high rate of false positive. So it way overestimated the prevalence, which then led to, when you compare that against mortality, that it looked like very few people with COVID died. And that really impacted early and continues to impact a lot of the public health responses in the US, which is why this matters. The same thing goes for mental health. We don't want to have high rates of false positive because this can lead to a number of challenges. It's a little bit ironic, that the group that published the original study on COVID and didn't address the false positives and led to these kind of public health erroneous recommendations is also part of the group that has done a lot of critique about how to improve the accuracy of mental health assessment tools. The main tool we'll discuss today is the Patient Health Questionnaire 9, or the PHQ-9. So the key issues with why we want to make sure we appropriately adapt and administer and analyze these tools is if we get lots of false positives amongst adolescents, we overburden the health system. We are predominantly working in low resource settings. We don't want to end up sending, 50%, 60% of all the kids in 8th grade to see a psychiatrist or a psychologist. That's just usually not possible and not even feasible. The other thing that really matters about why we want to appropriately adapt these is we don't want to stigmatize youth and their families. That saying you're above this cutoff, you have depression, you have anxiety, when it's actually an issue of the tool, not an issue of that person's life, we run the risk that that can impact how they see themselves, how their family sees them, how their teachers see them. Another major issue is you don't want to misallocate public health resources. If these tools are not accurately designed and administered, we can think that we need to put a whole bunch of money into an issue that's not a problem, which can then actually detract from other areas where mental health resources are really needed. And then lastly, just with the early COVID studies, inaccurate estimates means that we can't accurately compare against things like risk and protective factors. If we have all kinds of false positives in this work, and then we looked at all the other items on the mix indicators, we can't actually determine which of those are protective and which of those are risk factors in a particular setting. Okay, so from that adaptation perspective, the first thing is not a statistical issue, but really a qualitative issue. And what's great is there have been approaches originally developed by Mark Van Ormer at the WHO more than 22 years ago now, but have been widely used in diverse settings and adapted by the MAP approach, which is to use qualitative, rapid, brief, very feasible qualitative methods to get at the domains of equivalence to make sure your tool is functioning properly from one setting to the next. The technical terms that we refer to are semantic, content, criterion, construct, and technical equivalence. But the great thing is that the people that would undergo the adaptation process and conduct it don't need to worry about any of that technical language, because there's a process that focuses on much more accessible and understandable issues. The first is comprehensible. Are all of the terms within a particular tool understandable? Can you replace those with local idioms, local ways of describing something? For example, I do a lot of work in South Asia, and so the idiom tension is something that can very easily be a way to start a conversation about mental health, depression, anxiety, without having to use technical jargon. The next issue is acceptability. Are you asking things in a way that are acceptable in a particular cultural context? That has to do with how you ask about suicide. It's very important to ask about suicide. I'll describe how best to do that, but you want to do it in a way that's culturally acceptable. The second is acceptability related to adolescents in particular. Are you asking things that a parent, caregiver, or someone else might find unacceptable? The third is relevance. Does it make sense in that setting? We had to adjust a lot of our tools and beliefs because they were asking about things like, big movie halls, big malls, which just weren't part of the day-to-day lives of the youth there, and good ways to assess their symptoms. The fourth, and we can have a long discussion about this, but I'll just briefly mention it, is the response set. What are the options to endorse a symptom? Is it frequency? Is it severity? Is it a Likert scale? Is it a question? And those things are very important to make sure it's easy to understand. And then finally, completeness is the idea that it is associated with distress and impairment in some way. So there's a couple of different strategies to do this, but we've really tried to come up through MAP with a very streamlined process that can be implemented literally in a couple of days. You could at the fast track this, you could probably do this in 1 to 2 weeks and be ready to go. So what we say is don't do the forward and backward translation, because that tends to get you a verbatim, very technical approach. Instead, the focus is on getting more qualitative feedback, and there are really two key parties. One is local mental health professionals could be school counselors, psychosocial workers, could be psychiatrists, psychologists, and have them use these domains, these cultural equivalence domains, to go through each item, not to focus on accuracy of word-for-word translation, but to really think about the comprehensibility, acceptability, relevance, completeness. The best way to start this conversation with a mental health professional is not what are the technical terms, but how would you talk about this to your patients and families? That, however, is not enough. If we don't go to the actual intended audience and get their feedback, we still run the risk that this is not going to be a culturally equivalent tool, which is why focus groups with adolescents is very, very important. And that is very much using the same approach of sharing the different items with youth and then having them talk through how they would understand it and tapping into these different domains. Through MAP, we've been able to really try to streamline this process and recommend dividing out by gender and dividing out by age group, so you get different perspectives. But this is something that is very much doable, and we've seen lots of important modifications to the tools. The other thing I want to emphasize, because of personal shortcomings in going through this, is the language that actually goes in how you describe the tools, the instructions or a consent form, because that in and of itself can make an impact. We've done a lot of adaptation work in Nepal and really make sure that the tools like the PHQ-9 are culturally not stigmatizing. But one time when we administered this at a population level, we found very, very low rates of depression endorsement. And we were so confused, and then went back and looked at it, and the tool was fine, but in the form that had the instructions, it had a stigmatizing term, which was a direct translation of the words mental illness, rather than a culturally adapted way of describing it, heart-mind problems. When we went back and administered to a whole group, a whole new set of people, the rates of endorsement were twice as high. So that stigmatization matters not only in the items, but in the instructions. The next issue to really focus on is thinking about what is needed in the context to do this. Now, the biggest concern and barrier that we often hear is related to suicidality. People are afraid to address this issue because they don't want to make the situation worse. They're not sure how to respond. But we know for adolescents, this is so important. If we look globally, 1 out of every 3 suicides is amongst a person under the age of 25. So the key aspects of addressing the suicidality issue is it is crucial to screen. Simply taking out the items around suicide are not going to give you accurate prevalence rates of depression. And also simply by screening, you often open up an opportunity for dialogue and decreased risk. In all of the studies that have been done, asking about suicide actually decreases risk of self-harm, does not increase. Imminent suicidal risk is quite suicidal risk is quite rare. So typically, once you go through the process of appropriate screening, very few adolescents will need emergency services, and we'll talk about how that's done. And the fourth thing that is so beneficial now is that a lot of the immediate suicide risk reduction can be done remotely. This can be done over a voice or a video call. So enumerators can be trained that if they have a concern, to immediately contact a supervisor who has mental health and psychosocial training to be able to address what can be done. And most of that response can be done remotely. An individual, especially an adolescent, often does not need to go to a mental health facility. Often families can be instructed. And what's been great is that because of COVID, we've done a lot more on how to remotely manage, assess and manage suicide. So there's resources in the Equip Competency platform that was mentioned earlier, as well as a host of other tools and resources. The other thing that's really important, and again, this idea of context before going out and doing the surveys, is to get a sense of what are the ongoing services. So not those immediate needs related to suicide, but really ongoing support. So what we really recommend is to get access to any resource mapping activities that have been done. What is already there? What is in that community? That might be a government registry. It might be something that another UNICEF program has already done. Interestingly, in the context of humanitarian settings, it's often much easier to get the resource mapping because of the activities of technical working groups and technical coordinating committees. So a great resource is the 4W mapping that is pretty much universally done and UNICEF is often a part of. So getting access to the result of that 4W mapping already gives you a sense of what services are available in what settings to help you prepare for the larger survey study. Once that's done, you can refer to existing services. And the third option is, do you need to work alongside bolstering some existing services? Do you need to develop some additional resources? These can be simply things like adapting self-help materials for children and families, doing orientation programs for schools, NGOs, and CBOs, or if there's greater level of resources, training non-specialists in brief interventions. So the third point is then preparing the enumerators once you've done this mapping, once you've done your cultural adaptation. And I wanted to highlight kind of 6 key issues that are very important, even if someone has lots of experience doing enumeration work. How could they feel more comfortable operating in the mental health space? So the first is, within trainings, to really have an open dialogue around common myths and facts. One of the things that we deal with in a number of settings are ideas around mental illness is contagious. And if your enumerators think this, then asking about mental illness is going to be something that they're hesitant about. Or common myths in terms of what needs to be done to treat a mental illness. In some settings, it's for a young girl to marry early, which is the last thing we want, of course, our enumerators to be saying. But an open discussion of common myths and facts relevant to that context is very important. Discussing stigma and the impact of stigma, which is why people may not open up or why people may hesitate to ask about it, is very important. And the other thing is, whenever possible, when training enumerators, to actually collaborate with youth who have lived experience of mental illness, including suicidality. To have someone come to their training and describe what it's like to be an adolescent living with depression, or to have undergone treatment, or to have experienced suicidality. This can really help to reduce the stigma among the enumerators, and it helps them to feel more comfortable. In addition, other aspects are around when and how to break confidentiality, especially in terms of seeking support in the context of suicidality. Ideally, practicing with youth. It shouldn't be the first time when they're out in the field doing these surveys. It's the first time that they're actually talking to a young person. And then making sure that there's ongoing supportive supervision of enumerators because of potential issues related to the psychological burden of doing this. Now, fortunately, many of these enumerators already have experience in other areas like sexual and gender-based violence, child abuse and maltreatment, all of which would suggest similar levels of supportive supervision that are probably already happening. I just want to give one quick example. In Nepal, what we typically do is we train young people to take pictures to describe their experience of living with mental illness. They can then come in and either train providers or enumerators or research team members about that experience, share that with them, and also share what it's like to get help. When individuals who are doing the enumeration work have this mental image of people can get better, they're going to be more comfortable asking about this. Similarly, in our experience in Belize, we've been able to partner with young people with lived experience who shared their personal stories. Quick note, and I like using David Chang for this example, given his openness about his experience with mental illness, is being very clear that we want all of that adaptation process with mental health tools to happen in the kitchen, not on the part of the waiters, right? So it's the idea that you want to make sure you have a very intensive adaptation process, go through those issues of comprehensibility, relevance, acceptability, but that you don't want to either burden or expect the enumerators to do on-the-spot translations. This really runs the risk of getting hard to interpret information and using different types of examples that may inflate or deflate the information you're getting. So basically, a good waiter is very important, but you don't want your waiter to be changing the dish. Finally, just to wrap up, is the issue of accurate analyses. What we want to avoid is taking something like the Patient Health Questionnaire 9 or PHQ-9 off the shelf, and then amongst every adolescent in every country in every language of the world, we just use 10 as our cutoff score because Pfizer said to do that 20 years ago. That is not our goal here. What should be done is that we should be developing regional and ideally language-specific cutoffs. Now, that's not feasible to do in every setting and in every language, but hopefully through MAP and associated initiatives, we can at least have regional benchmarks. And what you can see here in the context of these PHQ-9 validation studies in 3 different countries that it does vary. It varies by language and it varies by age of the adolescents as well. But by establishing these benchmarks, we can give a government, a clinician, a school, another organization, funders, more accurate information of the prevalence overall. And just to show what that can look like is once you have the psychometric properties, or at least benchmark psychometric properties from the region and the language, is you can make adjustments to the numbers that come in when you do a national prevalence study in some way. For example, what I want to illustrate here is that if you did the PHQ-9 and then use the locally appropriate cutoff of 11, 9, 15 amongst adolescents, based on the results you get, you would actually need to do an adjustment to control for inflation and deflation because, again, these tools aren't perfect. But with that knowledge of the psychometric properties, we can actually make an accurate adjustment. So in terms of something like the Belize tools, they underestimate at low prevalence. And what we find is that there's a kind of an overestimation in a number of the other settings where this has been tested. But using a chart like this, it is very easy for a policymaker, a clinician to be able to make the appropriate adjustment to get an accurate estimation. What happens is as the prevalence on these scores, on these tools increases, the level of deviation from the true, or what we estimate to be the true prevalence, gets greater and greater, which is why you need to do more and more adjustment. But again, it's doable. We are generating through MAP and other initiatives the information to create these accurate estimations. So if for some reason you're doing a study in South Africa, you get a 30% prevalence rate of depression, you could adjust this and realize that actually you're probably closer to a 12% prevalence rate. This reduces that false positive and helps a government and organization really plan how to allocate their resources. So that's it. I just wanted to share one article that can be helpful, Measuring Mental Health in Humanitarian Crises, A Practitioner's Guide to Validity, which is freely available. And I'm excited now to turn it over to my colleague, Liliana. Thanks so much.
Thank you, Brandon. Liliana, when you're ready, please, over to you.
Thank you. Thank you so much, Brandon. This was an excellent presentation and very relatable to what I'm going to be sharing now. So very good transition. Hold on, I'm going to upload my slides. All right, can you see my slides in presenters mode? Good. Okay, thank you so much. So good morning, good afternoon, good evening, colleagues. It is my pleasure to present to you, following on Brandon's presentation and technical and very insightful introduction about what UNICEF is doing and has been doing for the past 40 years now in terms of developing methods to measure adolescent mental health at the population level. We call this effort NMAP. And I'm going to take you through the process, through what we're doing, telling you about field work and hopefully something that is very interesting to you. This presentation is divided into these 6 sections. I'm going to take you to the intro, the why, the what, and the how, the core domains that we are intending to measure, the process for adaptation and validation that are based on what Brandon has just presented. So we have been working together on this. As he mentioned, he has been the senior advisor of this effort. We're going to discuss data collection plans, data analysis, the potential that we have here, and I'll share with you some publications. First of all, one slide that intends to answer all questions. So let's go about that. So the why, the what, and the how. Why we're doing this? As you heard from already in the presentation, mental disorders are a leading burden of disease for adolescents. However, there's very little data on adolescent mental health conditions, especially country-level data. And one of the reasons why it's missing, that this data is lacking, is the need for culturally adapted and validated tools, and perhaps the challenges that have been already presented. This data, however, is urgently needed to be able to guide policies, programs to invest in adolescent mental health and mental health of the population in general. So what we're doing is developing a data collection toolkit that does include cultural adaptation protocols and implementation resources, so that countries who are interested in collecting this data will have all the necessary tools to conduct the work in a way that is feasible and doable, and will be able to collect this data. This is developed at the moment for population level measurement, but it's also something that can be used for screening of services and evaluation of programs. So if there are programs on mental health, these tools can also be used for baseline and endline assessments, and it's something that there's a lot of interest in that. And the idea is to use them among population of adolescents, 15 to 19 at the moment, and maybe even up to young people up to age 24. So what we're doing then, how we're doing it is through cultural adaptation and gold standard validation methods. So we developed the methodology and the protocols for this. We field tested these approaches in a few low and middle income countries, Belize, South Africa, Kenya, and Nepal. And we're in the process to field test it with the MIX program in Zimbabwe. The work is scheduled for July, so we're working on that very intensely with the MIX colleagues. And the idea is to adapt the module for administration in household surveys and prepare for future inclusion in MIX, provided that everything is in place. So the purpose and the whole intent of this effort is to contribute to closing that data gap. And how do we contribute to that? By developing the methods to make it possible, giving the tools, the technical tools to countries, and we're doing it in a very rigorous way, so that the heavy effort is at the beginning, is the foundation of the house, and then we can build with confidence and start collecting data that is telling us what we need to know. This work is led by UNICEF, it's in collaboration with WHO and other institutional academic partners. And the process has been, this is sort of a sum of a 4-year process. We started reviewing the evidence for common conditions and measures. We conducted technical consultations with the stakeholders and experts. We created a technical advisory group, what we call the MMAP TAC, and I'll tell you a bit more about that. And from that group, these technical discussions with the group, we identified the key domains that we needed, where we needed to focus our efforts. As you know, mental health is a whole spectrum. There are many conditions and concerns, so we really needed to be clear as to where to draw the line there. Following this, we selected the instruments that needed to be tested, adapted, and validated for the process. And keeping in mind our particular populations, UNICEF mandates is on children, adolescents, and we work mainly in low and middle income countries, so we needed to focus our initial effort there. And from there, we developed the protocols for conducting the cultural translation and adaptation and the validation of these instruments. And that followed with the process of analyzing the toolkits to be able to measure. This is what we're taking to the field test in Zimbabwe. So I mentioned our technical advisory group. So I wanted to give you a little bit more information about that. So our technical advisory group is very diverse. Is experts from countries from Australia, Brazil, India, Nigeria, Sweden, the USA, and others. So just to get a sense, it's from academic institutions, from international organizations. And our core team was based in New York, in DAPM, the Data Analysis and Planning and Monitoring division, with support from academic advisors and based in the US and Sweden. Also experts in household surveys and statistics. So from these discussions with the experts, where the core domains that were identified as priority, at least for this initial phase of the MMAP work, were mental health outcomes, in particular anxiety and depression. These two were selected based on the review of the evidence on the literature and on the global burden of disease. If you have seen the latest State of the World Children report, you may remember that anxiety and depression are among the top, causes of disease and disability among adolescents from the Global Burden of Disease. We have been looking. Another core domain is functional limitations, which is basically the way in which these conditions interfere with the lives of adolescents in various settings. In terms of suicidality, we're looking into thoughts and behaviors, we're looking into care seeking and connectedness, and what we call health-related risk factors like substance use and physical activity, and also body image. So we went ahead, and with these core domains being identified, we developed a tool to be validated in field countries. And the idea is that this will become a data collection module on mental health with plans to be included after all testing in MICS in 2023, provided everything goes well. So the idea of this tool is that it's a self-report tool. Basically, the questions will be asked to the adolescent. The questions are not going to be asked to a parent or a caregiver or a proxy respondent about the thoughts and feelings and emotions of the adolescents, but rather directly at the adolescent. And this makes a huge difference. And there's a lot of evidence about that. The tool is about 30 questions on these topics, plus additional questions on substance use and physical activity that the number are still to be determined. The administration time is less than 10 minutes, and some of these modules are optional, and so the tool can be slightly modified with the sub-modules, depending on the interest. There is some guidance about that. In terms of the actual content of the modules and the questions, right? That's a question that usually is very common. So yeah, you are talking about symptoms of depression and anxiety, but what are you asking exactly? So I intend to break this down a little bit here. So in terms of depression, we're asking 9 questions. These are based on the PHQ-9 tool, which is culturally adapted in the settings and validated for these populations, for adolescents, as part of the MAP effort. And the questions are basically asking basic symptoms, for example, having little interest on doing things, or problems with sleep, or feeling hopeless, or a number of questions that have already been predetermined as being symptoms of depression. For anxiety, the scale has 7 questions, and these are also trying to identify symptoms of anxiety, like feeling nervous, worrying too much, feeling restless, and other common characteristics of anxiety. In terms of the cultural adaptation that Brandon was referring to, the idea is to discuss precisely the language around these symptoms, right? Do people identify with this? Do adolescents really understand and feel related to this language, the way things are presented? These are translated into the local language. For example, so for Zimbabwe, we're translating all of this into Shona language. So when this is discussed in Shona, do we need to adjust this terminology? Are there idioms that are more common among adolescents when they talk about this in Shona language? So there's a really rich process there that really captures the essence of how people relate to their feelings and their emotions. For functional limitations, we have 3 questions, and it's basically questions about how these feelings interfere with daily life in their environment, being the family, the school, or their work, depending, or with their peers. On suicidality, we have 3 questions on suicidal thoughts and planning for the past year, and also ideation thoughts in the past 2 weeks, which is sort of like a more indication of like severity. For care seeking and connectedness, and there's a lot of interest in these questions. These are more in the space of like prevention and promotion of mental illnesses. We have 4 questions about the extent to which adolescents are seeking help, are speaking with others. And this is not just about like health systems. This is talking about with counselors, with parents, with friends, with their peers, and also the extent to which they feel understood by their parents. All of these questions have been prioritized also based on the evidence on the protective factors that for adolescents' mental health. In addition, we are adding some questions to be tested in terms of substance use, alcohol, tobacco, drugs, physical activity, and also body image. The number of questions is still to be determined there. So This slide is just to show you briefly the methodological approach that we have gone through with these questions. But just to say, this has been conducted in the 4 countries that I mentioned, but it doesn't mean that it has to be conducted if we move forward with the implementation. This was at the development methodological phase. So this goes back to what Brandon was presenting in terms of cross-cultural adaptation. Phase 1 is purely qualitative. We started with first of all, identifying if there was a tool already in the language of interest, like in Swahili or in Shona. So we talk to experts in the countries, and if there's a tool, we start from there. Then if not, then we conduct the translation with bilingual experts. Then we identify 2-3 mental health experts who in country and speaking English and the language of like the implementation can review the tool and identify, read through the language, to read through the items and identify if there's any issue for adaptation. And then, there's an important premise for work with adolescents, that is nothing about us without us. Of course, we talk with adolescents in the process. We conduct focus group discussions with them. And for example, in the 4 countries where we conducted the work, our focus group discussions included adolescents as young as 10 years of age. We had a group that was 10 to 14 and a group that was 15 to 19, separate. We discussed with them, and boys and girls separate as well. And then we followed up with cognitive interviewings. These discussions were basically looking into each of the questions on mental health. Before that, however, we had some, let's say, icebreakers and warm-ups, and we talk about how people talk about when they feel sad, when they are upset, when, trying to capture that language, trying to feel comfortable, the people feel comfortable talking about feelings, emotions. And that was really good. That led to very good conversations and opening up about all these topics. And after that, the tool is adapted and back translated into the original language, into English, to make sure that nothing was lost in translation, literally. And the second phase of our validation, which is what gives us the confidence to promote this tool as a validated tool. We administer the adapted tool, culturally adapted tool, into a sample of youth. Then this same youth, it was a sample of about 250 or 300 in each of those countries. We conducted diagnostic interviews using a clinical tool called the KSATs. So this is what is called gold standard validation. And after that, we were able to conduct psychometric analysis of data. Basically, the psychometric analysis is telling us how valid it is, the extent of like false positives or false negatives, as Brandon was indicating, and then give us the results to really move forward with promoting the tool for collecting data at the population level. So when we were conducting this process, something very important was to adhere to ethical principles and principles related to responsible data for children, which is something very important for UNICEF work as we conduct work with children and it's in the space of data collection. In terms of the 4 fundamental principles of ethics, the first one, beneficence or do good, the way it translates to our work and to what I'm presenting is that all this information is collected with the ultimate benefit, ultimate goal to benefit adolescents, right? This data will ultimately be used to inform programs, to inform investment of adolescent health. It's not just for research purposes or just for, for information. The second important principle of ethics is non-maleficence or do no harm. And the way we made sure this was in place was by properly training staff. You may remember from Brandon, like how staff needs to be trained in conducting these topics, having a referral protocol, taking action in case of need by respecting our respondents and being sensitive to the situation. The 4th fundamental principle is autonomy, and this is basically ensure that participation in these processes has been voluntary. There has been a right to withdraw at any point, and this has been informed very carefully in processes of informed consent to the parents, to the caregivers, and also to the adolescents. And then the last fundamental principle of ethics that we made sure was in place was justice. So it's equal opportunity to participate. Participants will be and have been randomly selected. But most importantly, the principle of justice is not that only vulnerable populations are selected to participate. Everybody will have the same opportunity. And in terms of the responsible data for children principles, these have really been part of our process in terms of the process being participatory, professionally accountable. This process has really been informed by global experts, academic experts, and working hand in hand with local experts in each of the settings. The process has been people-centric. As I mentioned, adolescents have been part of this, have been informing the process. There's the prevention of harm, as mentioned above. The process has been proportional, protective of children's rights, and purpose-driven. The ultimate purpose is to generate data that ultimately benefits the target population. So all of that process has been conducted in these geographies. Belize in Latin America, in Africa, we had excellent implementation partners in South Africa and Kenya, and in Nepal as well. We have a great team conducting the work. They conducted all the work that I described, and the data that is coming from these settings is really important, is what's really informing this process in terms of validation. We have additional discussions with countries from Peru, Jamaica, Angola, Zimbabwe, and we're discussing with Sweden, which is possibly the first high-income countries that will be using this tool. With them, we're discussing digital approaches to conduct all the phases that are necessary, and perhaps having a proof of concept as to how technology can inform the processes as we move forward. These discussions are also going on, possibly, with implementations in Jamaica. These processes are also under discussions with a UNICEF effort that is called the Data for Children Collaborative, in which technology and big data and these new ways of working with data are informing our ways to move forward and scaling up our plans. So I'm sharing here just a map of the MIX program, just to give a sense. We're working closely with the MIX program and moving forward into mixifying the process, the way in which this can be conducted. As you heard, this is a complex process. Mixed surveys are also complex. We're looking into simplifying the process in a way that it can truly be implemented in a way that is appropriate and it doesn't become a very heavy process. And the potential for this is that, as you know, MIX has a very big history of data collection, more than 27 years, 118 countries. And so we're working with our MIX colleagues really to inform how to bring this process from validation series that we have been conducted with a lot of rigor and like multiple steps into a simplified approach. And the potential is really enormous, as you can see in the map and in the number of countries. Once this module is adapted and is expected to be included in 2023, we could start having data on mental health. However, the module is going to be included as an optional module. Therefore, there's going to be an advocacy work that will be needed on every country that will include MIX to really advocate for the inclusion of the mental health module. So it's not automatic that next year all these countries will have data on mental health. It's going to be a process of, really advocating and working towards making it happen. I wanted to give a sense also of the analytical possibilities that we will have and that will help us understand the dynamics of the issues of mental health at the population level. So from the MMAP efforts, we're going to have about 10 indicators that I have put in bubbles here. You can see the indicators there on symptoms of depression, anxiety, functional limitations, indicators on suicidality, thoughts and behaviors, on care seeking that we can also call met need or unmet need for mental health, basically adolescents with conditions, with symptoms that do get support, do get to speak with others or not. And the indicators more on connectedness in terms of somebody to talk to or feeling understood by parents or guardians. So these are our MAP indicators. But once this module is included on a household survey like MIX, for example, we're going to have an array of other indicators that can be considered social determinants of mental health, as we see in the literature, or definitely important aspects that can help us understand or find, identify associations. So we have, first of all, demographic indicators like age, sex, geographic location, also other aspects like adolescent pregnancy, substance use, sexual behavior, learning and skills and education, and so on. So the possibilities are really extensive. In terms of social determinants, there's big solid literature in the Lancet a few years ago. Cricklund and colleagues published this article in which they are showing the associations of mental health with so many other SDGs. So the potentials for including these in a cross-sectional survey like MICS really expands the possibility of having, almost for the first time, indicators on mental health outcomes vis-a-vis other risk and protective factors that affect the population. So there are some examples here that cut across various SDGs, and these are just like, a variety of questions. So if we're looking at, let's say, SDG 3, that is all about health, we could have questions, try to answer questions like, are adolescent girls who are experiencing early childbearing more likely to have symptoms of depression or anxiety? We could answer that question if in a survey, the mental health module has been included, and then we have other questions that have been included in terms of early pregnancy and so on. So you can see across questions on poverty, on health, on education, reducing inequalities, even related to violence. So just to finish, because it would be important to have time for questions. So the MMAP package that we're working towards will include all these various aspects. Data collection, which is the questionnaire, the implementation material, which is adaptation and guidance for the implementations, training manuals, and so on. For data analysis, we will have the data processing tools, including computer-assisted personal interviewing tools, the manuals for data analysis, tabulation, and statistical softwares, and the templates for dissemination and interpretation of results. We have worked also into guidelines to adapt this process for phone-based. Our colleagues in Peru are moving forward with this approach, and it's really, really exciting to see this happening. And there are a number of publications that are already in the public domain. We will share this this slide deck, and the links are there that can, for more information about this process. Thank you so much. Looking forward to the discussion.
Thank you, Liliana. Thank you both, Brandon and Liliana, for these great presentations. We have a couple of questions in the chat box, and want to encourage other colleagues to please include any other questions they may have or reflections. I wanted to, before we move to the discussions, we have about maybe a little over 10 minutes. But I wanted to ask you, Liliana, if you could also mention and share if there are any other ongoing efforts to test similar approaches to measuring mental health in household surveys.
Thank you, Eva. Yeah, that's a very good question. We have indeed been working very closely with our colleagues at DHS, the Demographic and Health Surveys. They are also including a similar approach to collect data on mental health. They are including the scale on depression and anxiety and a few other questions on suicidality. And it's an approach that truly mirrors what we are doing. So we've been working together, more or less. We've been in communication with them about this. We learned that recently they have conducted field work to test the tools in a few African countries, in Uganda, in Mozambique, if I remember, and they have conducted field work in Nepal. So we are sharing experiences about how their work is going, how our work is going, and we're very excited about that because that would really increase the availability of mental health data across populations.
Thank you. So maybe moving to the chat box, Colleen had asked a question about why, it seems like we're like, even though there's mention of testing for children between ages 10 and 14, the decision has been to administer the module for ages 15 plus. And I think Brandon has addressed already that question in the chat box. I don't know if you want to come in and maybe mention or share your answer, Brandon. I think, yeah, maybe it'd be
or Liliana, I don't know if you want to say anything else about the plans for the younger adolescents, the 10 to 14-year-olds.
Sure. Yeah, thank you. So we, from the beginning, we definitely were very interested in including this younger population because there's, this sector of the population where there's least data. We included them in the validation processes. However, the results that we're getting from this validation are not very strong for that age group in terms of like the psychometrics are basically telling us that the results are kind of random, like results we're getting from them are not what would be needed to roll out the tools. So what we're thinking about is, starting with the 15 to 19, also to be aligned with the ongoing protocols for household data collection and household surveys. Start there and take a little bit more time to think about which approach would work better for these younger populations. So yeah, our moving forward is based on the evidence that we're getting, basically.
Perhaps sort of like a related question in terms of, who we're including and not in this administration of this tool. Munes had a question about children who cannot speak or talk. I'm guessing this means children who may have a disability, right? And so the question is, what are the tools options, if we have any, for administering these tools to these children?
Sorry, I didn't get the question. The question
Yeah,
is...
maybe Munas, if you can come in and maybe clarify the question for us. We can, are you, I think I'm probably unmute you. Yeah, the question literally is with children who cannot speak or talk, what are the tools options we have? And then just see, person has to be unmuted. Okay, well, while we figure out how to bring you in, there's another question about sampling by Irwanto. I have a question on recruitment of sample for the study. Did you ever consider respondent-driven sampling to ensure inclusion most vulnerable adolescents?
Mm-hmm. Yeah, thank you, Irwanto. Brandon, go ahead, please.
Would it be helpful to mention for me to mention the CCDT?
Yeah.
So one of the things is that all of this typically is done to look at kind of representative prevalence. And although that's, incredibly important information, it may not be the most effective way to identify rapidly the kids in need. And so another strategy that we used in conjunction with this and has been tested in other settings is called community case detection tool, or the CCDT tool, which I've developed in collaboration with a colleague, Mark Jordans at War Child, and we've used in a host of different settings. And so basically it's training teachers, community leaders, religious leaders to be able to identify kind of the prototypes or the vignette, like a vignette-based understanding of mental health issues. And then they can think about the kids that they're already working with and then be able to refer them. And that has a very high accuracy in terms of the kids that are getting sent, often are those kids that need care. We don't know about who gets missed with that process, but it is an excellent strategy to be able to rapidly get folks into services, and there are great ways to adapt those tools locally. So I do recommend for folks that are trying to kind of rapidly roll out services and then get the right children included. The advantage over respondent-driven sampling is that you don't have to go from kind of one group to the next group to the next group to wait for that effect to happen. You can do wide sensitizations of key actors in the community and then have them use this like non-questionnaire-based approach to doing referrals. And that complements the MAP methods.
Okay, thank you. Munas, I think you have been unmuted now, so you can please. Yes.
Thanks, colleagues. Is good presentations. I learned a lot. I do come with a background of working in a conflict-affected countries, including my country. I'm from Sri Lanka, and some other countries I work with. There are children affected by conflict and disasters who cannot express their suffering or mental conditions. And also by nature and also after the conflict. So in that context, what are the tools that we have to get their experiences out and programming to understand the situation where they are? I have a deeper feeling sometime our tool might exclude those children some point to how best we can explore their experiences. Thanks for the opportunity.
I'm happy to jump in on that issue. Thank you so much for sharing. And I just put in a link to that tool, the CCDT tool, which was specifically adapted for use in Sri Lanka. So that's a freely available if you want to look at that. So that is where I think that this cultural adaptation is so important. And there are kind of two aspects. One is using this more story-based approach to refer for services. But then if you want to get that representative data, then going through the cultural adaptation process to really get at the symptoms that matter most, the way of expressing mental health needs that really fits with that context. So we found, for example, in Nepal, that something like asking about appetite and weight changes due to relatively high infectious disease, parasite infections in rural areas, that's not a great way to look at identifying who has depression or anxiety. But if you ask about things like headaches, that's much more strongly associated. Similarly, some of the idioms of distress and the way that people describe suffering, when you incorporate those in there, for example, in Nepal, we talk about having a heart-mind problem as opposed to, say, experiencing depression. Those things are much more acceptable, less stigmatizing, and the children understand that. So I would recommend the same approach in Sri Lanka, going through the cultural adaptation process to be able to effectively identify who needs support and get them into care.
Thanks, Brendan, because I ask, in some contexts, there are child used for suicidal purposes. In my experience, yes, one was Sri Lanka, other one was Maiduguri, Nigeria. In both contexts I worked, I know their backgrounds. They were trained purposefully to be used as a suicide cadres and to get their stories. Those children, there are children who escaped from that training and mental, I know some cases they were from more than 5 years, more than 10 years, they were trained for the purpose, and some of them escape from that framework of mind. So how best we can get the stories from them, to understand what is going on and how we can re-get the man they lost, re-get the child they have lost through the process. Thanks, Brendan.
Okay. Thank you. So I think we have a couple more questions, and one, and also a reflection by Bull about he says, you have managed to scare me badly. Don't forget that the mixed program does not implement surveys and are widely stretched providing technical support as is. The non-typical burden of the presentation can be really overburden the preparations for implementation of the mixed survey. And I think this is actually an interesting point, because we've been, as in the preparation for the mixed field test, we have been really working to streamline and simplify the process as much as possible to make it visible, right, within the context of mix. Maybe Liliana, you want to speak to that a little bit, and Brandon, because I think your presentation was very rich and detailed and went through everything that you've done prior to implementation in household settings, but in household survey settings. So maybe you want to comment a little more on this. Yeah,
absolutely. I can come in quickly, and Brandon can also, if he wants to compliment. We are very mindful of that, Bob. Don't get scared. Don't get people scared around here. What has been presented is really the rigor and the methodology that was needed to develop the tool, to develop the processes. We're very mindful that realities in the field are very different in terms of resources, availability, time, and the pressures of any survey or effort like this. So where we are at the moment is, from all that, we learn from all that experience, and we are in the process of really simplifying and streamlining what's the bare minimum, but still, that will allow us to provide the quality that is needed. We're working with Brandon on that. We're working with Eva with all her knowledge of household surveys, and really making these implementation guides in a way that are doable and suitable. So yeah, we are very mindful of that, and with you on the concern, don't worry. Brandon, anything you want to mention there? Okay.
Yeah, there's also a question from Harayar about the, and this is just following up on, the potential insertion of this module within the mix. And so there are other modules in the mix that capture data on as part of the child functioning module on anxiety and depression. And his question is about, what are the is there any overlap between, or would there be any overlap between these tools, the module, the child functioning module and the mental health module, and how would this be reconcile if, you know, they were to be together in the same survey instrument?
Thank you. Yeah, that's a very relevant question, actually, and that's a question that we get very often. The child functioning module, their approach is very different from this. Their approach is about asking parents with like one question on depression and one question on anxiety to determine if the child is feeling depressed, to determine if the child is feeling anxious. So as you can tell from what we have explained, this is a very different approach because our approach is asking directly, is going into more detail. So we're very interested in seeing, once we have data from countries, for the two models, to see how the two set of questions relate to each other. We're looking forward to conducting that analysis, and we will be happy to share those results. At the moment, we only know the approaches are different, that are telling us different things. The child functioning module also is in the context of a number of other functioning, aspects of the child. So we're looking forward into having the data to really answer that question more, more directly.
There's a specific question about the time that it takes to complete the adolescent interview, and I think you mentioned that in your presentation briefly, but I think
based on our experience in those 4 countries, it is about 10 minutes. About 30 questions with all modules in place, and the time that it takes for this dialogue, because at the end it's a dialogue with the interviewer, is about 10 minutes.
And this is not like, we haven't tested this yet in the context of a household survey interview. And so that's, I think that information we will get when after the field test in Zimbabwe, I think we will get, get some more information about how long does it take in the context. We know that it's a little different. And I think this is it. I'm, aware of time. There was a question about how long it takes, from data collection, analysis, and finally to actions. But I think this is a longer conversation because there's so many factors involved in that, and especially depending on whether you actually include this in a household survey, national household survey that collects data on other topics, and et cetera. So. Yeah, I don't think we have an answer for that here, but happy to follow up with at least in the context of mix, we can provide some information about how long it on average it takes for results to be out. And Archana, please, over to you.
Yeah, I think Jay was also asking about experience with phone surveys using this data. I don't know if you want to spend a minute or two with that experience.
Sure, we're working very closely with the colleagues in Peru who have been actually working on the protocols to get this work done on the phone. And this is based on other experience in mental health. Maybe Brandon can tell us about a phone collection in mental health, which is actually like very common, right?
Right. That in terms of being able to reach large populations, that is frequently done. Again, there would be appropriate training in place if you identified a risk and how to handle that remotely. So you want to make sure that safety stuff is addressed. But yes, increasingly both verbally, but then also like text message responses that sometimes adolescents feel more comfortable doing. So something like a text message that asks for some of this information. So there's a host of different ways to do it.
Yeah, and if there's interest, we have produced the guidelines for conducting this work by phone. So we will be happy to share that with the person who is interested in this.
Great. Well, thank you so much, Brandon and Liliana, for a very engaging session today. And Ava, thank you so much for chairing. So we will wrap up the session today. Thank you all for your participation and great comments and questions. I just want to remind you that June 22nd is the next webinar, which is in 2 weeks, and it'll be on child food insecurity. And the week following, so the week after June 29th, will be the webinar on bullying and data collection. So just to note that there's not a 2-week interval between those two, but we will be sending out reminders and more detailed information. Also a reminder that the presentations and recordings will be available on our SharePoint site. That's a UNICEF internal site, but also the recording will be on the Mix YouTube channel. So we hope to see you in 2 weeks, and thank you again, Liliana, Brandon, and Ava.
Thank
Have
you.
a good afternoon, evening.
Thank you, everyone.
Thank you, everybody.
Bye-bye, everybody.
Bye.